Good evening, everybody. I'm going to be recording Chapter 47, the section on thermal injuries or burns. So let's start with characteristics of the burn injury. We want basically to determine how to treat a burn by three different issues. What is the extent of the injury based on the total body surface area? And that varies from child to child based on their age. What is the depth of the injury? And lastly, what is the severity of the injury? When we talk about depth of injury, we talk about some old-fashioned ways of describing it and some new ways of describing it. All of you are familiar with the idea of the first-degree burn, which is superficial, the second-degree burn, which is partial thickness, the third-degree burn, full thickness going through all body parts, and then the fourth-degree burn, full thickness, and also damage to the underlying tissue. This is a chart to help you look at the relative percentages of the area affected by a burn based on the age of the child. So please read through this particular chart to get a better idea of how we stage burns in children. This is the new way of categorizing burns. If you notice, you can see the full or partial thickness. You can see the old way that we characterized it, first, second, third, and fourth degree. What does the wound look like? What anatomical parts are involved in the wound? When do you lose sensation? And the course of healing. So this is a very helpful chart. This chart is right out of your book, so make sure you take a look at it. Now, these are the characteristics of the burn injury. Superficial is a partial thickness wound with intact blisters, and that's what you see in photo A. A superficial wound with partial thickness wound with blisters removed during debridement is what the number B looks like. Sometimes we remove the blisters, sometimes we don't. In the treatment of the burn, it just depends on what the treating physician thinks is in the best interest of the patient, and they don't always agree. Okay, this is a deep partial thickness burn, and that is the reddened areas on the patient that you're looking at. A full thickness burn, those areas are white on the patient, and a full thickness with eschar. And where is the eschar? It's at the top of the person. Those blackened areas, that is eschar. So if you don't understand what eschar is, it's a very thick, kind of like scab that develops on the surface of a very serious burn. The problem with eschar is that it doesn't expand. So if you have eschar on an area that has to move, like for instance the chest for respiration, then sometimes the eschar has to be broken up by cutting it so that it doesn't interfere with respiration. Eschar does not grow, by the way, and neither do the scars of burns. So this is very significant for children because they have to keep growing even after a serious burn. Now, we're also going to talk about determining the severity of a burn injury and how do we do this. First of all, we think about the body area involved. We consider the patient's age. We have to think about the concomitant injuries and if they already have an existing illness. And all those things together determine the severity of the injury. Children under the age of 2 have a much higher mortality rate from burns than all other children. and the rate is extremely high in an infant under the age of 6 months because they have very thin skin at that age. If a burn is determined to be a major burn injury, it needs to be treated in a specialized burn center. Moderate burn injuries can be treated in a hospital with expertise in the burn treatment area, and minor burns can be treated in an outpatient setting. Please review Table 47.9 for some additional information on this topic. I did work in a hospital that treated moderate burns in pediatric patients. It was very difficult to do that. So when we talk about burn injuries, don't forget that burn injuries can occur from a lot of different sources. We're all familiar with thermal agents, so that's things like fire, flame, hot surfaces, hot liquids. But you're also going to see patients that have electrical injuries and chemical injuries. And also you have to think about damage to the body from inhalation of toxic substances during a burn. We have to think about the pathophysiology of burn injuries. It is not just the burned skin. The body has a systemic response, and all the capillaries alter their permeability following a burn. So edema is an extremely huge issue in the immediate 24 to 48 hours following a burn. Because the capillary permeability changes, you have a fluid shift. Fluid shifts out of the capillaries and into the interstitial area. Also, you have, because of the fluid shift, you have hypovolemia. You've lost a lot of fluid during the burn and damage to the skin, and then the fluid shift occurs. And another thing that happens is the person becomes very anemic because they have lost a lot of blood during the injury. Now, edema is going to peak in moderate burns at 8 to 12 hours after the burn. So that means the remaining skin will be under the greatest pressure, and the person will be the most hemodynamically unstable at this time. Edema formation in larger, more serious burns peaks between 18 and 24 hours following the burn. Let's discuss the little boy in this particular picture, and what are we seeing here? Obviously, this little boy has a serious burn to his right arm and to his right chest. One of the rules of the care of burn treatment is that burn flesh cannot have contact with other burn flesh. So this arm had to be immobilized so that it would not lay on the chest. As burned tissue repairs itself and heals, two burns will grow together and cause an additional problem if we let them touch. You'll also notice that he has burns on his face, and he has a pressure dressing on his face to decrease the scar tissue formation. When we talk about complications of burned injury, we have the immediate period and then the long-term care period of a patient who has been burned. So the immediate period is threat to the airway, death from profound shock. When a patient has a burn, if it's anywhere near the chest, the shoulders, or the face, it can cause tremendous damage to the airway, either by directly burning the airway or by inhalation injuries, aspiration of toxic chemicals, and these things can cause pulmonary edema that can be life-threatening. After you get through the very first period, which we consider the critical period, where we're worried about airway compromise, profound shock, and inhalation injuries, then we move into long-term care of a burned patient. The main complication during healing or long-term care is infection. As a matter of fact, the number one cause of death following a serious burn is always going to be infection. Now, children have a much higher rate of death from burns than adults up to the age of 3. Once they get 3 years old, they have survival rates close to an adult. Pulmonary problems are a big issue for children, and pulmonary problems are the major cause of fatality in children with thermal burns or complications in the respiratory tract. The most common cause of respiratory failure in the pediatric age group from burns is bacterial pneumonia, and treatment for this may require that the child be intubated. Sepsis is a critical problem in the treatment of burns, so our response to that is that we want early removal of the eschar and also early autografting to reduce the rate of sepsis. So basically, we're talking about the removal of dead tissue to cut down on the amount of bacteria that's present near the burn. So let's talk now for just a minute about the picture here. Obviously, we have a child. I'd say this child is 4 to 5 years old. It looks like she has burns on her legs and on her back, and that explains the position she's in. She's lying on a special bed, and you'll see that she has burn dressings on but no covers to keep warm. So heat lamps are present to help maintain her thermodynamic stability. One of the big challenges that we face with children that are burned is to help them to maintain a stable temperature. So that's why we're using the heat lamps. So now we're going to talk about therapeutic management of burn injuries. What are our priorities? Our first priority is to stop the burning process. Then we assess the child's condition. We cover the burn to prevent contamination with a clean gauze. We want to transport the child to the appropriate level of care, and throughout this process we want to provide reassurance. I think I meant to say, when I obviously have put the wrong page number there, so I meant to say carefully review pages 1521 and 1522. Of course, there's a difference in how we deal with the minor burns compared to major burns. In a minor burn, we may stop the burning by using water, and we may or may not cover the burn, depending on how quickly we can get the child to further evaluation, or if it's just a very minor burn. With a major burn, we need to get the patient in a horizontal position to decrease damage to the respiratory tract. We want to smother the burn without putting the head under the cover, if at all possible, to decrease respiratory damage. We want to just cover the burn with a clean cloth. Remember that they're thermodynamically unstable, so we need to keep the patient warm, assess their airway and breathing, and transport them as quickly as possible. These are some of the major issues that we face with our children that are burned. So first priority is always going to be airway maintenance. Then we're going to address their fluid replacement. This is critical in the first 24 hours to replace their fluid and to achieve a fluid and electrolyte balance. We also are going to have to address their nutritional needs because they have an enhanced metabolic rate. In other words, the metabolic rate goes up when they are trying to heal, and so they're going to need a tremendous increase in calories during this period of time. So what we want to do is we want to meet their metabolic demands with high protein and high calories. And most children that are burned are not going to be able to eat the amount of calories that they need to meet their metabolic demands. So we will probably do some type of enteral feeding to supplement their oral intake. If we cannot meet their demands with an enteral feeding, then we're going to have to do TPN. So what kind of medications are we going to use in the emergency period? We're going to use antibiotics, lots of analgesics, and we also use anesthetics for the procedural pain of removing dead skin, debridement. We'll talk about that in a minute. Now, what kind of pain medicine do we need to use for our pediatric patients? We prefer morphine for burned children. So morphine is the drug of choice in burned pediatric patients. What are our fluid replacement goals? We want to compensate for the water and sodium lost in the traumatized areas and moving during the fluid shift into the interstitial spaces. We want to reestablish sodium balance, and we want to restore circulating volume. We also want to provide for adequate perfusion. We need to correct acidosis and improve and maintain renal function if we can. So we're going to use crystalloid solutions for fluid replacement during the first 24 hours. After 24 hours, we're going to use colloid solutions like albumin, Plasma-Lyte, or fresh frozen plasma. If you look at page 1523 in your book, it will discuss other drugs that are used in the treatment of burns. When we talk about wound management of burns in children, we have 3 steps. We need primary excision of dead tissue, debridement of dead tissue, and topical antimicrobial agents to help us to control potential infection. So we want to prevent the infection, we want to remove devitalized tissue, and eventually we're going to need to close the wound, which is the burn. We're going to need to close the burn. So during primary excision, we try to excise deep, partial, and full thickness burns because this reduces the incidence of infection and the threat of sepsis. This procedure is performed as soon as the patient is hemodynamically stable after initial resuscitation or stabilization. Partial thickness wounds require debridement as devitalized tissue to promote the healing process. This happens on a regular, ongoing basis. It's not a one-time event. So these times of debridement are very painful to the patient, so it requires analgesia and a sedative before the procedure. After debridement, we can do topical antimicrobial agents to retard the growth of the bacteria. Now we can slow the growth of bacteria, but we can't eliminate organisms from the wound. Now we're going to talk about how do we close the wound. Well, depending on how much damage the fire did, you may have to use, there may not be enough skin present to cover the wound, so we may use biological skin coverings for permanent skin coverage. And first we're going to talk about allograft, which is human cadaver skin. People can donate their skin at the time of death, and we can use these to accomplish the closure of a large wound if the patient doesn't have enough of their own skin to cover the wound. So we'll use different types of graft material. The sheet material, which is at the top of the page, is the most precious type of material that we can use. It gives you the best cosmetic effort on wounds, but it's hard to come by and it's very expensive. It may be cosmetically best, but generally you're not going to be able to only use this type of cadaver skin. So what we do to get more for the money is we do something called mesh, and that's what's in the other picture. We take a sheet of skin either from the patient or from a cadaver. You can do it both ways, and you run it through a machine that puts it into the form of mesh, and it can cover up to 9 times the area that it would cover if you didn't make it into a mesh. So it's a great thing to do, and it covers a lot of burned area, and so we like that. Now we go ahead and put the mesh directly onto the wound, and you just leave it there. It will naturally separate in the healing process when the wound heals. So you can think of it as a special dressing that's never changed. It lets you know when it's time because it naturally separates on its own. This is an example of taking a split thickness skin graft from a patient that's going to use their own skin to treat their burn. You can see that this is done in surgery, and it gets a very thin piece of skin gets surgically removed to use in skin grafting. There is another, and let me just say that you can use it as a full sheet like we talked about before with artificial skin, or you can use it as mesh, depending on what the patient needs. Now, there is a product on the market called Integra, and this is synthetic skin. It's extremely expensive, but it has significantly improved wound healing and decreased scar formation. It can be applied to serious burns, partial and full thickness burns. And once you get the Integra in place, then you put the patient's own skin over that, and it improves significantly the healing of the wound. Just to let you know, we can also grow cultured epithelium now, and we use pigs and rats in laboratories to do that. So that has been a big help to the treatment of seriously burned patients also. So let's take a look at some wounds that have been closed with some of these products we've talked about. The top hand is a sheet graft. The bottom hand is a mesh graft. And this is right after surgery when these grafts they're in the operating room when these pictures were taken. So these are serious wounds and the treatment of serious wounds. Now we're going to take a look at some more minor burns. If you're caring for a patient with a more minor burn, you would do wound cleansing. You would also do debridement, and in the case of you may or may not do debridement depending on the choice of the physician, and I want to mention again, they don't always agree. So some of them feel like you should leave the blisters alone because it's nature's own bandage for the burn. And then other physicians feel that you need to remove the blisters. So whichever way you're going to go, if you're going to remove them, that's called debridement. And then dressings, which is also controversial. You can cover the wound with antimicrobial ointment, and you can use an occlusive dressing. Where I worked with minor to moderate burns in children, we dressed our wounds, and that was just the protocol of the unit that I worked in. Okay, now, once the immediate phase ends, then your focus has to go to long-term care and rehabilitation of the patient. So long-term care begins once wound coverage has been achieved, and that may be within the first 2 to 3 days following the event. And so your focus has to come, now you're talking about the long-term issues associated with burns. And let's just review so that you're not confused. During the emergent or the resuscitative phase, which is going to be the first 24 to 48 hours, your focus is on stabilizing your patient with immediate fluid replacement and supportive respiratory function. During this period, you're evaluating your extremity pulses every hour to make sure that the eschar and the edema is not causing inadequate circulation. So once you get through that immediate, very unstable time, it's time to look to the future for the best outcome for this patient. So the rehabilitation phase is the long-term care that begins when the wound coverage is achieved, which may be the second, third, or fourth day following the burn event. So what we want to do during this time is we want to provide for prevention or management of contractures. We want to involve physical and occupational therapy. This will be a multidisciplinary team of people that will be helping for the best outcome for the child and their family. So what we want to do is we want to prevent burn injuries. And remember that the #1 cause of death is infection. So hand and forearm washing before people come in to visit the child are very important. It's also important for the staff to do very vigorous hand and forearm washing before you interact with the patient. We have to maintain their body temperature at all times, and our major goal is to avoid infection and sepsis. Research has shown that consistency of caregivers is very important. Another thing that is a very high priority is adequate pain medication and emotional support to the patient and to their family. One of our major goals is to prevent scarring. We want to prevent scarring instead of correct scarring, and we do this by using pressure dressings, like I pointed out to you with the child in an earlier photograph. And also we don't let one area of burn touch another area of burn during the healing process. The rule is no 2 areas of burned skin can touch. Another challenge that we have during this time is that children continue to grow, so we have to sometimes do additional grafting to make it possible for them to grow. Also, as they heal, they have intense itching, and so we're going to treat this with a combination of H2 and H1 agonists And an example of this combination would be Zyrtec and Tagamet. Now, scar tissue has no sweat glands, so controlling their temperature has to be very carefully watched. They can't tolerate high heat, but they also can't maintain their temperature sometimes. So we frequently check their temperature to make sure that it's within a normal range. And as I mentioned before, scar tissue does not grow. So sometimes additional grafting has to occur. Now, remember that when children are under a lot of stress, they regress. And so you should expect regression from your pediatric patients. Reassure the patient that the burn is not punishment. Reassure the family constantly. Parents have deep feelings of guilt if something horrible like a serious burn happens to their child. So you have to be prepared to be therapeutic, support the parents, support the child, and be prepared for a long-term period of healing. Thank you so much, and good luck on your exam.